Support for your public radio station comes from our members and from Smith Center for the Arts, presenting genre-bending mandolinist and singer-songwriter Chris Thile live in concert with a mix of classical, folk, and improvisation Thursday, October 16th at 7:30 p.m. Tickets online at thesmith.org.
From WXXI News, this is Connections. I'm Evan Dawson. Our connection this hour was made in Wisconsin with a woman named Patty. Patty had been religious about doing breast self-exams, but for a period of 3 to 4 months, she hadn't checked herself. And one day, what began as a seemingly normal day turned into a day that would change her life. During that delayed self-exam, she found a large lump. After a mammogram and ultrasound, Patty was told she needed surgery to have the lump removed immediately. The surgery was scheduled for the next day. I can clearly remember being wheeled down the hallway after surgery and seeing my doctor, my husband, and my best friend, Patty told Asperus Health, Wisconsin. I could see in their eyes that it was cancer, even before they told me, she said. Testing confirmed that the lump was cancer, stage 2. Patty was diagnosed at age 40, the age at which the experts recommend screening begin. Every October, the color pink can be seen on products and websites with the stated goal of raising awareness for breast cancer. Some advocates argue that, well, this is pinkwashing, as it's sometimes called, or it's commercialized the disease or put screening on the back burner. Well, this hour, we're talking about a lot of different aspects of this. Our local radiologist will share everything you ought to know about screening guidelines, who should get mammograms, when, and maybe even what insurance will cover. We'll also explore a couple different pieces of proposed legislation, one that could reduce barriers to screening, and a second that could help people with metastatic breast cancer access benefits. And I'd like to welcome our guests who are here to cover all of that and more with us this hour. Dr. Avis O'Connell is a radiologist with Rochester Regional Health. Easy for me to say. Welcome back to you. Great to see you once again, Doctor.
My pleasure.
Welcome as well to Christina Thompson, Executive Director of the Breast Cancer Coalition of Rochester. Thank you for being here.
Thank you for having me.
And Erin Park is a survivor advocate here. Tell your story. Nice to have you. Thank you for being here.
Thank you so much.
So let me just start with Dr. O'Connell. And, this is a conversation that that we know we have to have every year, and that, frankly, the amount of people listening right now who know someone who has been touched by breast cancer, it's enormous, and it's important to get the very latest on the screening guidelines. So let's start with this. Who should get a mammogram and when?
Mm-hmm. Well, being October, it's not that I always say that every month it should be Breast Cancer Awareness
I'm with
Month,
you there.
every month. However, in October, we get the chance to remind people, and I would like to remind people, as I always do, is that the screening guidelines, they're all over the place, but the ones that are mostly accepted are to start at age 40. That was controversial, to start at age 40 every year until 74. Afterwards, I'd like to tell you what happens after 74, because that's really important. But right now, a mammogram once a year over age 40, and importantly, it's completely covered at this time under the Affordable Care Act. No copay, no deductible.
Are you aware of there's a place that's Washington, D.C. is what it's called. And politicians there are arguing about coverage, about the Affordable Care Act.
Right.
There's even a shutdown about health care.
That's
people have to be wondering, is that going to affect getting covered for this?
Well, apparently the PALS Act will sunset in 2026, so hopefully that won't happen, because that part of that is this annual mammogram, which has been on the books since the beginning of Obamacare, way back, once a year over age 40 with no copay or deductible. And even though I said the guidelines end at 74, the screening can continue as long as the person shows up. Now, a lot of doctors tell their patients over 70, don't bother, you don't need a mammogram anymore. But 20% of cancers that we diagnose are women over 70, 75, and it's the highest decade. If you group the decades, the chance of getting cancer in your 30s is very low, like 1 in 200, and as it goes up, the 70s is the highest decade for the incidence of breast cancer, and yet the doctors are saying, you don't need a mammogram anymore. What they don't say is you can still get cancer, but somehow we don't think. I don't get it, because when all these ladies in their 70s and 80s come in, and I sometimes afterwards say, well, what's your thought on annual mammograms? My doctor told me I didn't need one over 70. But it's covered, completely covered, and as long as you show up once a year, your mammogram, your basic mammogram, not all the additional.
Covered until the age of?
Ever.
Yeah.
Show up.
So the guidelines that you're talking about, 40 to age 74, 40 to 74 once a year should be covered.
But people don't realize it's still covered over 74. The recommendations of when you should have
That's
one.
why I wanted to
Yeah,
ask you,
yeah.
if you were writing the guidelines,
Yeah.
would 74 be the end cutoff?
Well, you'd need to have an asterisk and say, as long as you're healthy, you can still, because if you're 75 years old, you still have at least 10 years by the actuarial life expectancy. You're still expected to live to your mid 80s. So why not? You know, if you're healthy and you don't have all the comorbidities that might shorten your life, all of those, you should at 75 you should live another 12 years, and some women are living into their 90s.
Well, so this is where I realized, Dr. O'Connell, that when you talk about actuarial tables, when you talk about math, it reduces a very human thing to math, and I understand why. I understand, but what I want to ask you is, I have a step grandmother who is 97, and if you met her, you might think she's 77. She's amazing, lives independently, does almost everything she's ever done at 97. My stepmother is in her early to mid 70s now. Oh, you would never think she's a day over 65. I mean, to say that they ought not be tested.
Well, here's why.
I'm confused.
Here's why. It's not that, but maybe people don't understand that that is the highest decade for getting cancer is the 70s, and the 80s are close by. But they feel like it's the false positives. So now, if I ask a normal person, what's a false positive? Oh, obviously you're told you have cancer and you don't. That's not the definition. The definition is you have cancer, but we don't think it's going to affect your health in your lifetime. So somebody's predicting that even if you get cancer age 75, it's not going to kill you because you're going to be, it's not going to kill you. But that's making a decision for that person. So the false positive only means we called you back, we did some tests, you never had cancer, we maybe even did a biopsy. You didn't have cancer. But the fact is that the cancer was small and probably wasn't going to, as I say, shorten your life or have clinical implications in your lifetime.
That you would die with it, not from it.
Exactly. Which is, yeah, exactly. But then again, if it grows more and you have to have surgery when you're old, most people, and if you ask most people in their 80s, if you got cancer, would you do not? That's the other thing. If somebody said, well, even if I got it, I wouldn't do anything. But if you say to any of, which I sometimes do, I see them, and of course they want at least the lump removed. They don't want chemotherapy. I don't blame them, and they maybe don't even need radiation, but they all want to do something.
Sure. My stepfather in his 80s had, he died at 91. In his 80s, he had a colon cancer and said, I want all the treatment except for chemo. I don't want chemo, but I want everything else. And tailored it to what he thought he could handle.
Yeah. So I think the women should be allowed, again, bringing the patient into the decision.
Yeah.
Like, yes, you could get breast cancer, but maybe it wouldn't kill you. Do you still want your mammogram? And if you get your mammogram and there's a cancer in there, would you do anything? And you'd say, well, of course. Then you should get the mammogram.
So don't just treat it like a math equation. Every patient would be different. And understand that when you turn 75, just because the guidelines shift, every person's going to have to make their own decisions.
And it's covered.
And it's covered.
Now, we have to say the first mammogram is covered. You all know, and that's why this Find It Early Act, the legislation is to try. And because I've had patients say, look, I know the screening mammogram's covered, but I know that if you call me back, then the insurance comes in and maybe I have a deductible or whatever. And this also brings us to, later on, you could ask about the supplemental screening, which is also part of the Act. If I tell you your breasts are extremely dense and you'd benefit from an ultrasound, I have to tell you, because there's a no surprises bill, that this is not automatically covered. In fact, it's not covered by most insurance. It's not covered by Medicare. But this new act that's stuck somewhere, the Find It Early Act, would cover supplemental ultrasound for people at higher risk if they qualify.
Okay. Now, I also want to ask you a little bit, Dr. O'Connell, before I turn to your co-panelists, about what we've seen reported in a number of media outlets, that we've seen an increase in cancer diagnoses among people under age 50. The New York Times says, this spring, researchers at the National Cancer Institute published a report showing that between 2010 and 2019, rates of 14 cancers increased among people under the age of 50 in the United States. Breast cancer and colon cancer on the list. And I'm not saying those are huge numbers, but they've gone up. Do we know why?
No. First, no is the short answer, but the answer is it's possibly many things. We do know, and especially breast and colon are the two I've seen most closely, but they're throwing out all the possible reasons. This is somewhere that AI might help. I reckon if you put a million cases into a big computer and put all the factors they had, what did you eat? Did you eat? You put all the questions in and you let the computer crank it out. But the lists of causes, potential causes, are childbearing. Well, somebody in their 40s, they maybe haven't had, but early childbearing protects. Breastfeeding protects. Drinking too much alcohol is a negative. Being overweight is a negative. Genetics, we don't even, and that's where AI, if you ask me about AI later, genetics is probably a big one. There are many genetics we don't know about. We all know about BRCA1 and BRCA2, but there are many, many more genetic aberrations that people have, and we're just finding out, ATM, of unknown significance. If we did genetics earlier on people and found a risk, and then environmental, okay, that's the final bucket. Could it be the soil, the water, the air, the microplastics? So nobody really knows, but this is the perfect time with the computers and the AI to feed all the info in on people with young cancers and see if it comes out. And the ones I know are healthy, fit, not overweight, not alcoholic, all these things. So these are in the category of people who we don't know. And they look healthy and they are healthy. I mean, I know several young people with colon cancer, and it's like they have none of these risk factors except the unknowns.
As skeptical as I can be about AI in a lot of aspects of society, I'm very optimistic of what it can do in medicine.
Or big data.
And it sounds like you are too optimistic.
Yeah. I am. And so the headlines are always like, will it take your job? So for radiology, the worry is, will it take your job? And I answer, no, it'll make us better. It'll make us better. We've been doing a type of AI for years. It used to be called CAD, computer-aided detection. Came in, FDA approved it in 1998. So we've been doing AI, if you like, for years. It highlights things like, did you look at this? And then if you hadn't, or you hadn't looked carefully, you look again. You ignore them if they're normal. But AI helps with detection. It helps with analysing the tumour to help with the treatment. It helps follow up the treatment. And then finally, and very significantly, it helps with the risk factors. You can put in risk factors you didn't know. Pancreatic, has that got anything? Men with prostate, does that affect the women with breast? So if you put all those in, and the AI then, it goes better than the Tyrer-Cuzick we all talk about now, and previously it was the Gale model. So there previously were models we used to give people their risk, but there's so much more to it, and there's new AI documents to say we can put other information in and come up with a different. The suggestion is that at age 25 or 30, women should get, a baseline evaluation of every risk that could possibly be in their family, and see if they should have enhanced screening. In other words, make their screening earlier or add more to it. That's that.
All right. So listeners, you've got questions, comments as we broaden this discussion, as we talk about breast cancer. 844-295-TALK. It's toll free. 844-295-8255. 263-WXXI. If you call from Rochester, 263-9994. You can email the program, connections@WXXI.org. If you're watching on the WXXI News YouTube channel, we ask you to like and subscribe. That's great. And join the conversation there in the chat if you want to do that. So let's talk about, I think, one other aspect of this that probably everyone in the room would agree on, which is, Ava's even put this in all caps, don't ignore symptoms. So if you're going to leave something with people today about symptoms, Dr. O'Connell, you first here. What do you want people to understand?
So if you don't have, this is a basic truth that if you don't have a screening mammogram and you're one of the unlucky folks to get a cancer, you're going to find it yourself. And the things not to ignore are any lump, any discharge or nipple changes, pain that's unusual for you, not the usual period pain that we're all aware of, but I mean unusual focal pain. Don't ignore symptoms, and don't be embarrassed to say, I went in, I thought I might have had something, and they told me it was just lumpy breasts. That's okay, or just a cyst. There's no such thing. It's like that's the best news if we tell you it's nothing. So don't ignore symptoms, even if you've shown them to them before and they said it was nothing. We've had people come in, and I showed it to my doctor a few months ago. They said it was nothing, and now it seems bigger. So when you look at it, you don't want to say, but they should have come in sooner. So don't ignore it.
Christina, as the executive director of the Breast Cancer Coalition of Rochester, I know you help people of all ages. Are you seeing younger people come in needing services?
We definitely see a full gamut of ages in general, but one thing I really loved that Dr. O'Connell was talking about was involving that patient in the scenario. And it was referring to the patient 74 and older, but I think we can do the same on the other end of the spectrum because, first of all, if we ask for a raise of hands right now on who was diagnosed before 40, we're going to see several in this room. And so it's the same kind of thing. Know your body, know the changes, don't ignore something, and bring it to the professionals if there is any change or just anything that seems out of the norm.
And you want to talk a little bit more about what the coalition does here, what kind of supports and services you offer, and then we'll talk a little bit more about kind of some of the landscape of legislation, metastatic breast cancer, and more. But tell people about what the coalition does.
So the Breast Cancer Coalition is an organization that here in Rochester, we're on University Avenue. We offer free support, education programs for anybody with a breast cancer or gynecologic cancer diagnosis. And there's no age limits. There's just nothing there. You're going to find a staff of really supportive individuals. Some of them have had a diagnosis themselves. Some are just fantastic support people. Quickly, you will learn that you're not alone, and we can really help with having this person with a diagnosis become a very informed decision maker, to learn more about what options may or may not be on the table, giving empowerment to seeking a second opinion if something seems off, or just getting that validation that, nope, same opinion. And then we can also get you connected with someone who's had a similar situation so you can ask those questions. What would be helpful for me after surgery? Or how did you combat certain side effects with the treatment that I'm expecting to have? You can talk things out. There's nothing that can't be discussed within those walls.
I know that there's a piece of legislation that's been on your radar for a while. We're going to talk about the Metastatic Breast Cancer Access to Care Act coming up. Let's get Erin's story in here first because I think it's important to understand it. So, Erin, I'm going to give you the floor and tell us a little bit about your story.
Okay, I think it's important for my my story that begins with my youngest sister. She was diagnosed with breast cancer at the age of 29. She passed away 16 months later. And so that's kind of guided my decision making. I did go to get mammograms, and as well as my middle sister, and probably 4 years after she passed, it was one of those things where I did notice something, and went to and had a mammogram, and you kind of go to another room, and you could kind of you're in there for a little bit longer, and you find out, so you're getting kind of very nervous, and they wanted me to take a biopsy, and it did turn out to be cancer. I had
Bilateral?
Yes, bilateral mastectomy. And when that was, biopsied after the surgery, I had stage 3 cancer, which will tell you that it's in my bloodstream. But I was getting close to that five year mark where you have more, maybe more confidence that you're going to beat the statistics, and probably 4 years and 4 months. I was in the office. I was a nurse. I was in the at the office, and I couldn't speak, and I was just lucky that my coworker noticed. She was a nurse practitioner, and she noticed that I couldn't speak, and she kind of ran me down to the emergency room, and it turned out to be a progression to my brain. And so I have issues with my brain language issues, and so that was hard. I was there continued to work for about 2 years, and I ended up. It was more. There was more progression in the brain, and then I ended up having a craniotomy. And so that was kind of the end of my working career, and that was really difficult for me. And so that's kind of where the Breast Cancer Coalition, I loved working, and once things settled down, I was able to work at or volunteer at the advocacy committee and also the research committee. So that was great. And then as things progressed, a little more than a year ago, I had progressed again to brain cancer, or sorry, my bone cancer, but I had a lot of support from the Common Grounds group, which is a bunch of mostly ladies with stage 4 cancer. So that was amazing to have that kind of support, people who really knew what you're going through. And but I'm able to walk, still go to Wegmans, that kind of go to and talk to my friends, and it's so I guess that's my story.
Yeah, I just want to read a little bit of what you wrote for the Breast Cancer Coalition, because I think this will help the audience even appreciate your story a little bit more. You said that, quote, "To be honest, I've only begun to accept it. And by accept, I mean it continues to frustrate me on a daily basis. My brain is funny now, a source of comedy and difficult to explain or understand. I stumble with numbers, letters, colors, everything you learned in kindergarten. I know the words, but they spill out of my mouth too fast before I find the right ones," end quote. You're doing great on this program.
Oh, thanks.
I appreciate
Thank
you telling your story. And I think it's important for people to hear this, not because, again, this is every breast cancer case, not the case, but we're talking about all different kinds of breast cancer. And let me ask our other guest, Christina, what do you want, first of all, people in general to understand about metastatic? And then we'll talk a little bit about legislation here.
Well, it does happen to be the perfect day for it. It is National Metastatic Breast Cancer Awareness Day. And I think that really what it does is bring awareness to people like Erin and a lot of other people like her that are living with this stage of the disease. A metastatic diagnosis means that the cancer has left the breast and has spread to a distant organ. And it is treatable, but it is not curable. So those are people that are going to be in treatment for the rest of their lives. And that's a very different story that I think sometimes the pink ribbons in October do not get to explain.
Okay. And when it comes to what can be done, what's happening out there, the Metastatic Breast Cancer Access to Care Act is out there. What should we know about that?
So this is currently in its 4th Congress that we've been working on this. And currently, for someone like Erin, just to use you again as an example, thank you for coming, we have people that are diagnosed with metastatic breast cancer under the age of 65 and will continue to live life normally for as long as they can, be it working, raising families, doing whatever they are doing. And currently, if they were to decide that they no longer were able to work due to treatments or the disease progression itself, they currently face 5 months of waiting for Social Security disability to become their new income and a subsequent 24 months for Medicare to be their insurance. And you are talking about somebody who is in a terminal disease. They cannot go without insurance or without treatment during that time. So this Metastatic Breast Cancer Access to Care Act is asking Congress to change the Social Security Act to waive those wait times. These are people who have paid into both of these programs for their entire career. They are deemed disabled and are privy to these. However, those wait times are there for a different reason. And also, these wait times have been removed for folks in the same situation who have ALS and end-stage renal disease. So we know it can be done. We just need to add metastatic breast cancer to the list.
Dr. O'Connell, anything you want to add on metastatic?
Well, I have to say, I think it was extremely brave of you to come and be, on live where you can't edit it. I mean, that was fabulous. I really applaud you for that. So, no, I suppose you could say that the earlier a diagnosis is made, but it's not always possible, and for younger people who aren't even thinking of cancer, except when there's a family history, I think it boils down to if you could get your risk factors checked early enough, and you got screened early enough, and you didn't have to worry about paying for the ultrasound that you might need, or the MRI. I mean, we haven't even gone there. The cost, the thing is the cost of care, that if the mammogram is covered, and of course a diagnostic is not, it's a screening mammogram is covered, the cost can sometimes deter people, and we shouldn't underestimate that. If you need an MRI, that costs thousands of dollars. And even with your insurance, you may have a copay and deductible. So the other act that I just mentioned briefly was the Find It Early Act, and that was to allow people who have a higher than average risk. Now, unfortunately, not everybody, but a higher than average risk to get supplemental imaging with ultrasound, which isn't as good as MRI, which is the best. I mean, if I ruled the world and money was no object, everybody over the age of, depending on the risk factors, could have a free MRI. And there are ways of having cheaper MRIs because there's an abbreviated MRI and there's the full-scale MRI. And the results from the screening MRI, the abbreviated MRIs, which some people will offer, well, that's another whole subject, but it's a much shorter exam and the time on the table is less and the cost is less. And if something like that could be used, there's a survey from England where they did that, and the results, the extra cancers found on the abbreviated MRI were like 17 per 1,000 after the mammogram was negative. It's unbelievable. And those cancers would be sitting in there. And so nobody knows they're there until they feel them. So I think the access, what was it called, the Find It Early Act, would allow that people like that could get supplemental imaging covered in the same way the mammo is covered.
I agree that definitely should be implemented, but I will say that we are lucky where we live in New York State specifically. When I was diagnosed, I had no medical insurance. I worked full-time in an office, but it was a very small office, so that was the loophole. They didn't have to offer any medical insurance. However, we've got the Cancer Services Program here, which basically if you're uninsured or underinsured and you need a screening mammogram, also pap smear and colorectal exam, they will cover you for the imaging necessary. And obviously in a program like that, they're going to run into a number of people who do have a positive diagnosis. You can then be enrolled in Medicaid for active treatment, which was the case for me. So, there are some fail-safes, but I will say to Evan's point about DC being a hot mess right now, some of those programs are on the chopping block as well. And in New York State, the federal government decides how much money towards Medicaid they're going to provide, and New York State matches it, and we are one of the highest in the state. But it allows us to have access to programs like that.
But people have to know about them.
They do.
Yeah.
Can I, let me just get a couple other listener comments, and then what we'll do is we'll take a break and we'll read more feedback from the audience. But maybe related here, Mary writes to say, I'm a survivor, diagnosed at 70. Breast Cancer Coalition has been a wonderful support with information. If diagnosed early, survival can be long-term. I'm amazed at the number of young women in their 20s and 30s being diagnosed now. That's from Mary. So, Mary, thank you for that. And not only a salute to the coalition, but the wonderful medical care you're getting in this community. And David wanted to know if your guest, he's talking about Dr. O'Connell, wants to weigh in on whether you prefer the health system here or in your native Scotland.
Oh, Scotland. Nice. Actually, my grandmother, I have a lot of Scottish in my DNA. I'm Irish, of course. Yeah, of course, as Evan knows.
Okay, you're not Scottish. You are Irish.
No, I'm part Scottish.
Have you ever practiced in Ireland?
Oh, yes.
Okay, so
yes.
David wants to know what you prefer.
Well, If you need something, you're fully covered. But to get the diagnosis, so screening is every 3 years, and I think it starts at age 50. I mean, I haven't practiced there for quite a few years, but screening is every 3 years, same in the UK, every 3 years. And so a lot of interval cancers, which are the aggressive ones, can happen in that 3 years. So but if you are found to have a lump, you don't pay a penny after that. Once you have a diagnosis, your treatment is free, but the waiting list, it could be months before you get your surgery. So, yeah, I'm appalled that this country here does not have, at least a lower level of... In Ireland, if you're Irish, you get covered, basics like Medicaid almost, but you can buy more to add to it without disallowing your original one. So anybody who's an Irish, and I actually updated my passport, so if I get sick in Ireland, I can wander in. I'm back to being, I'm both now. But, you can be completely covered with no bill at all. You can buy insurance to get a fancier room or fancier something, but it's the treatment part is better. The diagnosis part is not, or the screening part is not at all.
Let's take our only break. We're going to come back to your questions, comments from the audience as we talk about breast cancer of all kinds, screening guidelines, what you ought to know. If you've got questions, comments about metastatic or everything else related to it. We're talking to Dr. Avis O'Connell, radiologist with Rochester Regional Health, Christina Thompson, executive director of the Breast Cancer Coalition of Rochester. Aaron Park is the survivor advocate. We'll come right back with your questions and comments next.
Support for your public radio station comes from our members and from Mary Cariola Center, proud supporter of Connections with Evan Dawson, believing an informed and engaged community is a connected one. MaryCariola.org.
This is Connections. I'm Evan Dawson. Let me get an email from Roger, who says, I just wanted to throw this out there. Though very rare, men can also get breast cancer. I had a suspicious lump and, long story short, ended up having all or most of the fatty tissue removed from my chest. I think men really need to be more cognizant of any changes in their bodies. That's from Roger. Dr. O'Connell, what do you think?
Well, that was going to be one of my bullet points. The people we don't talk about are the women over 70 and the men. Mm-hmm. And honestly, it's only like 1% of the cancers around are in men, and they don't get screened routinely. We do have men who show up for screening because they know that their family has the BRCA gene, which is more common. BRCA2, most men, when they get breast cancer, you find that they had that. But so men, well, there's two sides to this. One, they have less breasts to check. I mean, their only way of doing things is to notice a change. So, I mean, if there's a lump, they should not assume. And we see lots of men with lumps, and luckily most of them are benign. Mostly it's gynecomastia. But it's great news. They come in, they're really scared. Everybody who has breast lump, male or female, any age, they immediately go to, I've got cancer. And it's an anxiety that's not necessarily there. And it's a whole psychological thing. It's not as big a, other imaging like screening lungs, people don't seem to worry as much. But the minute somebody thinks they have a breast cancer, they are more scared than almost any other cancer. Anyway, so men should just be aware of any lumps, knowing that most of them will be okay, but any nipple changes, if the nipple starts turning in or discharge, that's a huge red flag.
Roger, thank you for that. Anything you want to add there, Christina?
We've definitely had men who seek out the coalition, and absolutely. And I think especially this month when we do a lot of outreach and we're speaking, I think a lot of people are shocked to learn that men can have a breast cancer diagnosis. So the more we talk about it, the better.
Yeah.
Roger, thank you for that. Allison says that there is cancer in her family. Should she start screenings earlier than 40, Dr. O'Connell?
Well, that depends. So if the red flags for earlier screening are if the person in the family was a first degree, first of all, but if it's not a first degree relative, if it's young, if the patient was under 40 or perhaps even under 50, if the patient was premenopausal when they were diagnosed, the person in your family, that's one flag. If the person, anybody in your family had bilateral breast cancer, that's another red flag. If there was a man with cancer, that's another flag that feeds into the last question, that if there was a male breast cancer in the family, that's a red flag. Multiple family members who had breast and ovarian, because that's a genetic link. So there are several red flags that the physician in charge of doing your care with you would be able to highlight, but those are some of the red flags that says you might be at a higher risk. So to start before age 40. Usually we don't start mammograms before 30, but we certainly do mammograms on women in their 30s. There are two reasons. The radiation is not the biggest risk, which will ask all the questions about radiation. But the risk is that at that age, the mammogram's often not very helpful because the breasts are too dense. But if somebody had a problem, so screening mammograms in the 30s, unless there's high risk, wouldn't necessarily be the way to go. But it's very variable. What we would do is an MRI. If somebody had a really high risk and we calculate 15 to 20%, they might be recommended to have an MRI, not a mammogram.
I'm sure that this is one for the experts, but Christina, how often are there questions, in the coalition experience, just of when people should be getting screening and how confusing that can be?
It is confusing because it's so individualized. There is not just a blanket statement. And I think that it's got to take those factors that Dr. O'Connell was saying into it, as well as the changes that one might feel themselves, knowing how some of those outside risks of lifestyle and things like that can elevate. And then just having a solid primary care doctor or OBGYN that you're seeing regularly that you talk about these sorts of things.
So you mean for the younger screening?
I do.
think most people agree that 40 to 75, it should be every year, although some people say over 55 you go to 2 years. But anyway, I think what you're mentioning is the younger people.
folks.
Absolutely.
Right.
Yeah.
Some questions about who is opposed to some of the legislation that's out there. So the Metastatic Breast Cancer Access to Care Act, the extension of other pieces of legislation. What's the active opposition to some of this, Christina?
It's mind-boggling. We have a congresswoman in New York State who we were on a Zoom call to talk about all of this, and we had a physician living with metastatic breast cancer on the call. And the congresswoman cited her fear was fraud, that people would fraudulently say that they have metastatic breast cancer in order to access Social Security disability income and access Medicare. After that call, she actually has frozen us completely out of her office. So the Breast Cancer Coalition and our survivor advocates are not granted meetings when we're in D.C. or in New York State. We have constituents of hers living with metastatic breast cancer. She will not budge.
It's my job to ask you which member of Congress.
Claudia Tenney.
Can she be shamed?
I think she should be. This is inhumane treatment for people who have paid into the system over time, and now you are telling them that their life isn't worth waiting 29 months.
Could somebody do a calculation? How many has any fraud ever been discovered? Anyone? If you ask her, show us one case, even one case of fraud that has happened where somebody actually said, who in their right mind would say, "Oh, I have metastatic breast"? I mean, you'd be struck down.
Did she say to anybody in that call that she had evidence that people were using metastatic breast cancer fraudulently?
No, I believe it was just her blanket statement towards Medicare coverage in general. That
She's
too much
concerned
fraud
about
in the
waste,
statement.
fraud, and abuse.
Yes, exactly. Whereas her colleagues, Elise Stefanik, Nick Langworthy, have signed on in the past. Nick Langworthy has not yet this year with Congress again. We are very hopeful that he would. His office has been very helpful to us. She has been the major holdout.
What about, okay. So, helpful update there. I don't think the Congresswoman's going to come on this program, but she is invited, and we will make another effort. She certainly is welcome to talk about this and a lot of different things, and I hope she does. I hope she will. She will be treated fairly. There are a lot of important questions that people ought to have for her. And Christina, my guess is, as the executive director of the coalition, you don't view your job as a political one.
Not at all.
So
cancer doesn't have a political party.
So for you to be this pointed on the air about a sitting member of Congress, you must feel like you've been pushed.
Well, I would love to hear her thoughts because in previous congressional years, she did sign on. And then she became a member of the Ways and Means Committee. So there's more kind of financial oversight, and perhaps that was her thought. But it's a major holdout on something that we have people fighting for their lives over this. I have folks that are a part of our Common Ground group who are living with metastatic disease. And while they know that the months are shortening for them, they have to continue to work because they carry the insurance for their entire family. And those are the decisions people are having to make right now because she won't sign on to this.
Yeah, reading a survivor's perspective from your coalition newsletter, person says, Quote, having early access to Medicare would mean that I could go out on disability now instead of trying to push through until I qualify at 65, 9 years from now. Right now, it seems I will have to work until I die, not because I want to, but because I have to.
Unacceptable.
Aaron Park, what is it like hearing members of the government question whether support for patients with metastatic breast cancer should be there, or if that should be taken away out of concern of fraud?
It's horrible to hear that. We've been into DC, or at least I have, for 2 years, and I've watched some of my metastatic friends who are, I guess was lucky because I had a major epileptic event, and I ended up with a 4-day medical coma, and that helped make it was easier for me to qualify that way. And and along the table, I have friends of mine who are literally dragging themselves to work every day, and it's really it's very disheartening to see a member of Congress to do that and not take our calls. It's just horrible, I think.
Are you aware, Doctor, of you seem to be not aware of any fraud cases?
Oh, I'd love them to be asked. Show us. Now, there may be fraud and abuse in Medicare in general, but specifically in metastatic cancer of any kind, because they'll also say the minute we allow it to the breast cancer, they're going to want it for prostate. Well, they should.
Right.
Here's something that nobody ever discusses: the stress and worry and physical toll of going to work when you have to because you don't qualify. That in itself is not good for your, because there are things we don't understand about why some people do better and less well with the same diagnosis. I would say if you let people not be so stressed about getting to work on time in a snowstorm, it would actually help their care. Of course, that's caring for people, not counting the beans,
Exactly.
But I would question anybody who says there's fraud and abuse. Yes, there is in Medicare, but show me one case where somebody said they had metastatic cancer and didn't.
Back to your feedback. Ellie in Rochester shares this story from breastcancer.org. COVID and flu may activate breast cancer cells in lungs. And reading from the story, people with a history of breast cancer may want to consider COVID and flu vaccinations, according to researchers. Common respiratory infections caused by viruses may be able to activate sleeping breast cancer cells in the lungs and could lead to metastatic disease, according to database and mouse studies. The study was published in the journal Nature. Are you aware?
No, I'm not aware. However, I would say that I think people should get the flu and COVID vaccine if they can. I do believe that those two vaccines should be taken. I have not seen anything that it activates. Mind you, if you're sick and your immune system is flagging, we know that the immune system is very important in fighting cancer, but that connection is kind of nebulous, and it makes sense. Just like when somebody is stressed out, it's not healthy to have to make their way to work. So, no, I hadn't seen that study, but
Get vaccinated.
The vaccines are good.
Okay. All right. Joel in Rochester on the phone next. Hey, Joel, go ahead.
Oh, hi. Yeah, I was just wondering if your guest had any comment about the exclusion of other metastatic cancers from that legislation. Why is it only metastatic breast cancer that should get early access to these resources?
Yeah,
Panels?
I mean,
Yep.
that's a valid question, and I know that this is policy from the National Breast Cancer Coalition, so they are a federal umbrella for groups just like ours here in Rochester. We support their public policy, and they wrote this legislation 4 Congresses ago, so that's a great question, and I think if there are other organizations out there like a prostate group and they wanted to do something similar, they could certainly gain from the momentum that we've got. Both of the waivers for ALS and end-stage renal have been in act for a long, long time. And so we are still fighting very hard for metastatic breast cancer. That's all I.
Well, it might improve the argument if several other. I mean, why not every metastatic cancer? Because that definition of metastatic is significant no matter where the original organ is. So yeah, he makes a good point. But but the Breast Cancer Coalition is not going to just add in prostate.
Correct.
But it'll make it easier for the prostate folks.
Okay. Joel, anything you need to add there?
Oh, no, that was it. Thank you.
Okay, no, fair points there. Let me get an email from a listener who's asking to withhold their name on the air and says the following. I'm curious about recommendations or thoughts on screening for women diagnosed with DCIS triple negative after lumpectomy and radiation. Dr. O'Connell?
Well, the guidelines from the NCCN, it doesn't even matter who it is, the guidelines are once any cancer has been successfully treated and the radiation is finished at least 6 months before, they can return to normal. They should have normal screening. They don't necessarily qualify for the 20% lifetime risk of cancer MRI because they've already had cancer, but it's possible. So that person, and we see them every single day, should definitely get a mammogram once a year. It's every 6 months till you get to 2-year mark, and then it goes every year. But of course, anytime we think there's any change, we start doing more things. But there's no different screening at this point, except just have the regular screening.
DCIS, by the way, is what for people who don't know?
Ductal carcinoma in situ, also known as stage 0. Also, some people say isn't really cancer because it's still confined to the basement membrane. If it's not cancer now, would be my line, it will be almost certainly cancer in your lifetime. Some DCIS progresses really quickly, some take several years. But yeah, DCIS is the least invasive. It's not invasive at all. It's non-invasive cancer in situ.
Okay. Working with triple negative, any progress? Does that remain?
Triple negative tends to be more aggressive.
More aggressive?
Yeah, but I've never seen anything that you'd get screening more often. I don't know if that would qualify you for an annual MRI. Everybody's individual. It's, if the surgeon or the oncologist chooses to order an MRI for some reason.
And again, triple negative just means the question of what is fueling the cancer.
Yeah.
And it's not known.
And most cancers are estrogen positive, progesterone positive, and HER2 positive or negative. The triple negatives are none of those. They're estrogen negative, progesterone negative, and HER2 negative. And they tend to be more aggressive. They're quite treatable, but they tend to be more aggressive. And so, but if a doctor, if the referring doctor, oncologist, or surgeon has any concern about recurrence of a DCIS, triple negative or otherwise, and they choose to order an MRI for possible recurrence, that's a whole different scenario. We're mostly talking about screening right now, but people can get breast MRIs for potential recurrence or residual disease. That's a different conversation.
All right, before we close the program, Erin Park's been here to tell her story as a survivor advocate, and we've talked a lot about where things stand with resources, with legislation. What do you need most in your own life right now?
That's a good question. To be honest, I don't need much. I have a lot of friends that I've met through the Breast Cancer Coalition, and my family is very supportive. I think probably the biggest frustration for me is mostly the epilepsy that I was incurred as part of the and that seems like it's getting better as far as driving. I'm able to drive now, but it's those little things that you had highlighted in my essay, is that a lot of times I will say things backwards, or and it's kind of become like a family joke at this point. You're like, wait, did you just say that? And it's a lot of compassion from my friend's family and the Breast Coalition. So I feel like I'm fine.
Well, I've really appreciated you sharing your story here today.
Thank you.
It's really important It's important that we understand. I mean, certainly probably everybody listening has had breast cancer somewhere around them, if not directly in your family. But it's important to hear these stories. And Erin Park is just one survivor advocate. There are many more. Christina Thompson, Executive Director of the Breast Cancer Coalition of Rochester. What do you want to leave with listeners today?
I want to say that if you are living with metastatic breast cancer or gynecologic cancer, you're certainly not alone, and we'd be happy to meet you. All month long, we are running our Cindy L. Dertinger Advanced Breast and Gynecologic Cancer webinar series every Wednesday at noon, and we've got our previous ones that are recorded and shared on our website, and they really are topics for people who are living with or caretaking for somebody who has metastatic breast cancer. Topics include things like pain beyond the physical, managing total pain, navigating PTSD and cancer survivorship. So they're really universal topics, and we'll also feature survivor speakers.
So access it where?
Right on our website at bccr.org.
And Dr. O'Connell, about 30 seconds. What do you want to leave with people here?
Well, thank you for having me, and I am really honoured to be in the presence of our lovely advocate here, and I think understanding and compassion would be what I would wish for you. And I'm always happy to hear Christina with the Breast Cancer Coalition, I know, and GYN goes from strength to strength, and I'm very happy to be part of this discussion.
Well, I want to thank our guests for a very important conversation this hour. Dr. O'Connell, radiologist with Rochester Regional Health. Thanks for being with us as always, Dr. O'Connell. Thank you to, she's not Scottish, she's Irish. Thank you to Christina Thompson. Nothing wrong with being Scottish, by the way. Christina Thompson, Executive Director of the Breast Cancer Coalition of Rochester. Thank you for being here.
Us.
Erin Park, good luck to you. Thanks for sharing your story.
Thank you so much.
And from all of us at Connections, thank you for listening. Thank you for watching. Thanks for finding us on the many platforms we're on. Share with your friends and neighbors, and we'll be back with you tomorrow on member-supported public media.
This program is a production of WXXI Public Radio. The views expressed do not necessarily represent those of this station, its staff, management, or underwriters. The broadcast is meant for the private use of our audience. Any rebroadcast or use in another medium without expressed written consent of WXXI is strictly prohibited. Connections with Evan Dawson is available as a podcast. Just click on the Connections link at WXXInews.org.